morning. My name is Liljestrand, and I originally was an OBGYN, but have spent the last 35 years or so on global maternal health in a broad sense.
Ajoke Sobanjo-ter Meulen, and I'm by background an pediatric infectious disease specialist, and then worked in global health, bilateral aid, and then clinical vaccine research development in industry, so Merck and Novartis, and then joined Gates Foundation 4 years ago. And here I'm working on maternal immunization, which is what we're going to talk about, and working very closely and collaboratively with Ajoke, which I think is great. You know, having vaccines and maternal health in partnership doesn't happen that often. So I'm very excited about this program, and thanks for hosting us. Okay. Okay, so first of all, I think I just want to start off with providing some background and context why we're supporting and investing in this field, which is maternal immunization. So starting off with the disease burden and then talking a little bit about what's in scope for us for maternal immunization, because sometimes that differs depending on what institution you talk to, be it the regulators, be it OBGYN. So I think we have a very focused scope here. And then talk through a few examples of past programs for all of us to realize that it's not really an entirely new concept. And then discuss and review some of the new vaccines that are in development, which is why I think this is a great opportunity right now to find new synergies across programs and work outside of our usual silos. So one of the overarching goals of the Gates Foundation is, especially in global health, is to reduce neonatal and childhood mortality. And very significant progress has been made, with the Millennium Development Goals, about a 50% reduction both in maternal as well as child mortality. But what was seen is that the neonatal mortality didn't decline at the same rate as child mortality, which is why we still face about 2.6 million neonatal deaths every year. And this continues to be incorporated in global health development goals. So the SDGs continue to have both neonatal as well as child mortality as one of their goals, or of our goals. So which is why we continue to be on global health strategy with these strategies. And so when you look at neonatal mortality, you can see that about a quarter of the causes are due to infection. So these range across pneumonia, tetanus, meningitis, sepsis. Of course, not all of these would be addressable by maternal immunization, but it shows you that infections continue to play a significant role, especially in very low-income countries. And then there's another bucket here, which is preterm birth, and that's a bucket that's ill-defined, because if preterm birth is the cause of death, then there's no further categorization as to whether that was associated with an infection. So we can make the assumption, I guess, informed hypothesis that there's a significant proportion of infectious preterm death as well. Okay. So this is just a different way of looking at what has been achieved to date and what we are striving for. So this is the reductions in mortality during the Millennium Development era, which is 2000 to 2015. And so the shades of green and blue here reflect the percentages. So we had about a 4% annual reduction rate here. And I think stark contrast here is that if we want to achieve the SDG targets, this has to be increased to about, and this is the legend here, to about 6 to 8% reduction in mortality per year. And this is to say that we need to focus on what can we do better. Of course, we realize there are a lot of existing safe and efficacious interventions available. Those need to be scaled up, etc. So this is not a competitive strategy, but we want to be complementary and address those diseases that cannot be addressed otherwise. Here, this is another way of seeing that there's a shift, disproportional distribution, there's a higher percentage of neonatal death amongst the overall under 5 death. And this is specifically in sub-Saharan and Africa as well as Southeast Asia. What has not been measured under the MDGs are stillbirth. And shockingly, the numbers here are approximately the same as neonatal death. And this is not a component, this is in addition to the 2.6 million neonatal death. And I think IHME is now also starting to incorporate this in the global disease burden estimates, just to be able to track. And again, maternal immunization aims to address a proportion of these stillbirths as well. So these are our newest estimates that we use to inform our strategies. And here you can see that Group B streptococcal infection plays an important role in stillbirth. And again, we don't want to overlook the 200,000 stillbirths caused by syphilis, but we're not talking about syphilis today. I just need to put it up there to put it in perspective. So Group B strep, GBS, is one of our maternal immunization targets. And with that vaccine, we're hoping to both address stillbirth, so meaning infections that that occur intrauterine, as well as perinatally and causing a neonatal death. So this is the number that's usually tracked, which is death within the first 3 months of life caused by GBS. And our second target, and which is actually the most advanced maternal vaccine right now, is respiratory syncytial virus vaccine. This number here is the under 6 month death, newest estimates. And for RSV, the story is slightly different, obviously, because infection doesn't occur before birth or during delivery. But we're trying to address RSV infection in the neonatal as well as infant period. So what is maternal immunization? So maternal immunization is vaccinating pregnant women to provide protection to the mother, fetus, and infant through transplacental transfer of antibodies to confer immunity. And just for context, sometimes vaccines that are given both before as well as during pregnancy, such as Zika vaccine, that's a good example, or Hep E vaccine, they actually need to be given before pregnancy, but then also include pregnant women, are also summarized under maternal immunization. But we only focus on vaccines given in pregnancy. And for the new vaccines, they actually have to be given in the second or third trimester. So which again differs from, for example, tetanus and influenza, which can be given at any time during pregnancy. And what's really unique about maternal immunization is that you're vaccinating one individual, which is the mother, but then depending on what the pathogen is, you could potentially protect the mother, the infant, so the fetus, or the unborn, or however you want to call the baby, infant, as well as the infant. So it's basically three, you could see it as three populations, which makes it intriguing as in terms of the potential impact, but also much, much more challenging in development, just from an ethical perspective, regulatory licensing, etc. Because the benefit risk for that vaccine now needs to be evaluated across the mother, the fetus, as well as the infant. So what are we actually trying to affect by basically elevating or enhancing the transfer of antibodies? This is a phenomenon, it's physiological. So infants or neonates within the first 2-3 months of life are entirely dependent on maternal antibodies because their immune system is immature and cannot sufficiently either produce own antibodies or for most vaccines in infancy, they cannot be given prior to 6 weeks of age, again because of just either interference or insufficient immune response. So we're trying to close this window, the so-called window of vulnerability, and to bridge over to when the infant is then able to either respond appropriately to infant immunization, example there being tetanus as well as pertussis. So pertussis, there the window is within the first 2 months of life, or to elicit antibodies that the infant could not make on her his own. And this is another graphic to just illustrate what's in scope for maternal immunization. So it's infection-related death, potentially a proportion of preterm birth and stillbirth, and again that it's both the mother, the infant, as well as the fetus that are protected. Little bit of focus on maternal health. So it's a continuum. We see this as a continuum. So not just focusing on one particular window. And the continuum of maternal infant-child health. And here are 3 examples of maternal vaccines that we already know. So for GBS, it's potential because we don't have a licensed vaccine there. But for tetanus and influenza, we know that these 2 vaccines confer protection in the mother as well. We'll talk a little bit about influenza because that actually triggered a change in approach or perspective to maternal immunization. So women have been vaccinated during pregnancy since the 1800s. It wasn't called maternal immunization, but it was realized that infants born to women vaccinated against smallpox fared better than those who were born to mothers who were not vaccinated. And this is a series here of vaccines and examples, either given for in specific situations, so meaning family medicine outbreaks, but then also, of course, routine immunization, etc. And with the perspective of limiting use in pregnant women, same as for drugs. And then in the 1970s, the entire pregnancy intervention platform was influenced by the thalidomide scandal. And this is really and one has to realize that that wasn't a drug, a medicine that was indicated for pregnant women. So it was basically given off-label with no appropriate safety studies or even efficacy studies. But that led to a turnaround in regulation, and the FDA basically directed that women should only be included if the benefit risk is clear, and that it was basically an approach of risk avoidance. And I think conceptually this is what stuck with people over the next few decades. And the first significant change here happened with the 2009 influenza pandemic. Because here pregnant women were seen as being at highest risk for severe disease and morbidity and hospitalization. At the time it was also thought for mortality, but later on, because of post hoc analysis, etc., it was primarily morbidity and hospitalization. So that led to a change in recommendation for influenza vaccines. So all countries with routine influenza vaccine programs were now switching to prioritizing pregnant women. This was really a first. Again, many things right now we take for granted, and this is just the past few years here. The next significant event that happened was a resurgence in pertussis mortality, neonatal, in the US and other high-income countries using acellular pertussis vaccine. And here, pertussis Tdap was introduced as a maternal vaccine, both in the UK as well as in the US. And the UK was able to do population-based effectiveness studies, which then later on showed that it prevents severe disease and mortality in neonates. But this was done in the absence of efficacy studies. So when these programs were initiated in 2011, 2012, there were no efficacy or safety data or effectiveness data available in pregnant women. But because, and this is about perception, first of all, of course, it's a vaccine that has been used in millions of adults. But on the other hand, it was also seen as unacceptable that any infant should die of pertussis in the US or in the UK. So especially in the UK, there was very high population pressure on the government to implement these programs. But what they did is they showed that vaccinating in pregnancy is safe for these vaccines and effective. And subsequently, many other things changed. So the WHO came out with recommendations for both influenza and pertussis. The FDA changed their clinical development guidance for vaccines. There was no guidance on how a company could get to licensing a vaccine for maternal indication, etc., etc. And then finally, we landed where we're at right now, which is we have the first vaccine in phase 3 development, so which is the late stage clinical development of a vaccine for pregnant women, and that's respiratory syncytial virus vaccine. So this is a list of vaccines that are currently recommended for pregnant women. So it's quite a bit here, and then there are these 3 here which are part of routine immunization. So tetanus, TD, mostly in low middle income countries, and then influenza, pertussis in high and middle income countries. There's still not many new vaccines in development because it continues to be a challenge, and we've got these 2, which we'll talk about in a minute. So for tetanus vaccine, Africa and Southeast Asia, one of the most successful vaccines, so led to I think nearly a 90% reduction in neonatal tetanus, and 43 countries have reached the target of 1 per 1,000, and WHO, UNICEF, etc. continue to incorporate this in their global vaccine action goals. And maternal immunization here continues to be one of the 4 key elements of reduction of maternal neonatal tetanus. And so at the time, so this is in the 1960s, there was an immediate reduction of about 30% of neonatal death. So this is overall, not just tetanus, because at the time tetanus played such an important role proportionally in causing neonatal death. Okay, so I don't know, do you, Björka, do you want to maybe share a few words about this? This is about the collaboration and partnership between MNCH and vaccines. ANC, I think that's what we want to get at ultimately. What role antenatal care and PI plays
perhaps just then saying a little bit about maternal health care and maternal health in low and middle income countries, because this is the vaccine trajectory that Ajoke has described. So what's going on in maternal health care, where we need to deliver these vaccines, probably as of 1 jab around week 28 to 30. So let's just take a very, very rapid look back, and starting in the 1960s, we could say that in the 1960s and 70s there was a common belief that you could fix maternal mortality by investing in training of traditional birth attendants. For various reasons it didn't work, and one moved on in the 70s and 80s to say that antenatal care would do the trick, where one would discriminate between the women who actually needed to deliver in facilities versus those that could deliver at home and being low risk. Unsurprisingly, perhaps, if you look at epidemiology today, most of the complications around childbirth are unpredictable, and therefore you cannot decide that this is a low-risk woman who can give birth at home. So this was then reverted in the 1990s when a broader discussion started. Is it about skilled birth attendants, or is it about emergency obstetric care? And the jury was out for 10 years. The jury came back and said it's both. We published on it, we wrote and saw what successful countries had done. And then since about the millennium, beginning of the millennium, we have seen a very, very huge increase in facility births. So countries like, let's say, Ethiopia or Cambodia, they had 10, 12, 15% facility births at the beginning of the millennium, and today they have 90%. DRC has 80, 90% facility births. So we have invested a lot in facility births, and have really had our hands full and still have in providing quality care, because if you double and triple and quadruple the number of clients that come to understaffed and under-resourced services, you will find women on the floor, not mattresses enough, no gloves, no midwives, no disinfectants, all those things. We're struggling with those things, but I would say that the funding is coming, the efforts are coming, quality improvement. But in this light, antenatal care has been in disarray for the last 15 years. Contributing was also the fact that WHO came out in the late 90s with a guideline that said it's enough with 4 antenatal care visits for the low-risk woman. And somehow downplaying the role of antenatal care. And that's the reality we have lived in. So when we look in the last 20 years or so, antenatal care in low-income countries has been very poorly monitored, and the way it's been monitored is that it has been monitored in the number of visits. How many visits, how many did those 4 visits, and how many didn't, and not really seeing what is the content of the care. So for now, as we see antenatal care as the main platform, there are alternative platforms, let's say outreach to communities and so on. But the main platform is really antenatal care. So antenatal care needs to be strengthened for maternal immunizations, but it also needs to be strengthened for its own right. So we have had our hands full with the other stuff, skilled birth attendants around birth, emergency obstetric care, women who are bleeding, getting access to cesarean sections and all those things. But now we also need to invest much more in the big things that need to happen in antenatal care, need to be monitored. Let's say you saw syphilis on the slide, 200,000. So we need to do an effective screen and treat for syphilis. We need to do the malaria prevention better, be that bed nets or the intermittent treatment. We need to do the anemia screening and treatment better. We of course need to, and these are non-obstetric things if you wish, there are other programs that also use the antenatal care platform, but we have obstetric stuff like hypertensive disease, like preeclampsia that needs to be detected and screened for. We have the HIV screening. So we have 5 or 6 important things that needs to go on and happen on a regular quality basis in antenatal care. And that's why we need to monitor and strengthen also, the strengthen action and monitoring come together and really improve antenatal care in the coming years. We cannot now rest on our laurels that 90% of women come to facility births. Now is the time to work more on antenatal care. And in a timely way, WHO has issued new guidelines for antenatal care. It came in October 2016, a year and a half ago, and they say 8 contacts, not 4 visits, but 8 contacts, meaning that some of these visits need not to be on a one-to-one basis with a provider. They could be group antenatal care, they could be outreach, they could be community health workers, but there's a contact where you actually check on the woman. Otherwise you will lose many, many babies to stillbirth and also many mothers. So now is the time to strengthen antenatal care in its own right and also for maternal immunizations. So this leads us to this slide. Sorry for the long preamble. But then looking at what are we doing now to successfully eliminate and eradicate tetanus, newborn and actually also maternal tetanus. So this is an ongoing study that the WHO is doing to see in 90 countries of the world where this is an issue, how is tetanus vaccine being delivered to pregnant women? Is it really the maternal health folks that are doing this, the midwives and their assistants, or is it the EPI programs, or is it a combination of those? So that's what is answered by this slide. So to the left, you can see how actually of the maternal, there's a preliminary data from 80 countries, the final results are yet to come in the coming 9 months, but you can see to the left that most of the tetanus immunization, TT vaccination in the headline, is actually happening in facility-based antenatal care routine services. So most of the tetanus vaccination is going on there. There are also some where this is happening perhaps in the health center compound, that the woman comes to the antenatal care service for a visit, but then also goes over the compound and gets a shot at another facility or another function in the same health center or health facility. But who's actually doing the work around this? You can see that to the right. Who's managing it? The procurement of the vaccines is EPI, the planning, the distribution, and the training is very much EPI. So we can see that this is really an effective collaboration at the grassroots level, which is kind of unsurprising thinking of when you get down to that kind of primary healthcare level. These are few people, 3, 4, 5, 6, 7, 10 staff in one facility, and they collaborate in an effective fashion. But what we do see here, where we have to learn maternal health people, is that the EPI people, they're really an asset in organizing this. The way they have fixed the tetanus problem, let's draw on that as we move ahead and see if the EPI people can not only help us with the maternal immunization, they perhaps can help us firm up antenatal care. So the other contents that are non-vaccination, let's say the malaria or the syphilis, the other thing, we could use them as an asset at the local level. Most maternal tetanus vaccination is administered by A&C, but EPI leads vaccine procurement, supply, and delivery. So they are jointly managed. This is basically what is going on in countries.
Okay, great. Thanks, Jörg. And I think important to discuss maybe later on, you talked about the opportunities. I think there are also worries about, resourcing. How can we do this? EPI, I think thinking of delegating to MNCH and ANC, and then worry that perhaps ANC staff might be overwhelmed. So I think we can also discuss a little bit about that. And we just had a very interesting meeting, primarily with country level stakeholders and experts. And maybe Jörg, you can share a little bit of MNCH.
We'll discuss exactly that. But I also think we need to see the evolution here. Let's say that the epidemiological situation we have today is not the one we had either in 1960, 1990, or the year 2000. That now we jointly need to focus more on the perinatal period, that much of the low-hanging fruit of under 5 mortality decline, that has been harvested. Now we need to add on different things, and the maternal health care has evolved not only on the at birth care, but here we also have a new chance to invest in antenatal care jointly and move forward if we want to meet those SDGs.
Okay. So just quickly, influenza data here. So this is a study that the Gates Foundation, it's actually 3 studies in 3 locations, South Africa, Mali, and Bangladesh. And this was the first maternal immunization efficacy study that was done in low-income countries. And it showed that both in the mother as well as in the infant, there was about 50% protection from lower respiratory infection caused by influenza. And what also came out later on, and this is looking at studies, again, this is the first, the efficacy studies are prospective studies. These are data that are mainly drawn from retrospective cohort studies. And this is about complementarity. So interestingly here, there's a reduction of severe pneumonia, but then there's also reduced severe wasting, as well as, in a positive sense, improved growth at 16 weeks. So I think this speaks a bit to what Jörg was just alluding to, that a lot of new interventions need to be complementary, and they're also, I think we're also taking a little bit of a different perspective on maternal neonatal mortality, in the sense that we see this as a trajectory or continuum starting in pregnancy or maybe even at conception, and then all the way to childhood. And that you can see that women who start off on a, in parentheses, negative trajectory, be it due to infections or nutritional issues, that their infants fare worse. So if measured, there are several ongoing studies right now, I'm not sure whether you are involved with any of them, where at 1 year of age, you can link birth weight as well as mortality in the infant to status of the mother during pregnancy. So with maternal immunization, we're also hoping to positively influence that trajectory. These are data just to substantiate the pertussis story here. This is taken from the US. So one of the big challenges we're dealing with are the data gaps from low-income countries. So we don't have comprehensive primary epi data to build on, pertussis being a very good example. But I think the pertussis story is also different from high-income countries. So here in the US, you can see 3 months of age, so that this is reported death over the period 2000 to 2012. And most of the death here occurred below 3 months of age. And this is exactly the period before infant pertussis immunization kicks in. And so the Tdap maternal vaccination programs were initiated, and these are data from the UK. The UK has achieved about 70% coverage with their pertussis immunization, and you can see that infants born to vaccinated mothers, basically no deaths seen here, and so this is age at onset. And this one here, this is where the resurgence occurred, 2011, 2012. and when the maternal vaccination programs were initiated, and you have a reduction to 2. And if you look at the data in more detail, you can also see that those infants are either born to mothers who received vaccine too late in pregnancy, so basically they were like right before delivery, so where there was not enough time to elicit an effective immune response. And this has led to these changes in recommendations, and here of relevance to low-income countries. This is actually an important learning, because this is an example of a maternal vaccine that works. We know it works, but the infant pertussis burden, mortality burden differs. And we started out with an approach where we thought that this would be a vaccine that could be a Gavi-funded vaccine. And we did several epi studies as well as review of ongoing and completed studies within the past few years. And it turns out that countries who use wholesale pertussis vaccine in their infant immunization program seem to have a very, very low rate of infant pertussis death. So there's obviously a difference in herd protection and immunogenicity of acellular pertussis and wholesale pertussis vaccine, so which is why the recommendation here is that it's for countries with high infant pertussis burden, so it's not a general recommendation. And right now, it's a complementary approach for low-income countries, with the primary approach being trying to achieve highest coverage and earliest onset of. Okay.
Because if I may add 2 things there. One is that we have done a refresh of our MNCH strategy at the Gates Foundation over the past year, and one conclusion of that is that we must concentrate more on the pregnancy, birth, and the first 59 days. That the babies that succumb after 2 or 3 or 4 years of age, they are not any babies. The high-risk babies for death in that period are the ones that already has some trauma during pregnancy, birth, and newborn period, being low birth weight, preterm, infected, malnourished, malaria, whatever. So we are increasing our efforts in this window of various types, including maternal immunization. I've lost my other one. Go on.
So you'll be on in just a few more slides time. So just 4 more slides from me, and then it's for you to discuss the MNCH perspective. So I quickly want to talk in just 4 slides about the 2 maternal vaccines that we are supporting in development right now. Starting off with a Group B streptococcus vaccine, which is really the, I would say, MNCH example for a maternal immunization approach. So Group B streptococcus infection mortality in the infant, it starts off with colonization in the mother. So that's vector-vaginal colonization. And worldwide, it ranges between, let's say, 15 to 30% of women are colonized, including in the US. And so which results in about 21 million women colonized globally. And so all those women are potentially at risk. And in the US, there's a standard of care implemented, which means that all women in pregnancy get screened. I think it's at 33 or so weeks gestation. And those women who test positive, they receive intravenous intrapartum antibiotics, penicillin. And since introduction of that approach, 80% of death in infants caused by GBS have been prevented. I mean, a reduction, 80% reduction. There's a slightly modified approach to that, which is you give antibiotics to women who fulfill certain risk criteria. So, for example, premature rupture of membranes, etc. And some other countries do that, including in Europe, and that doesn't work as well. So they're actually even seeing an increase in incidence right now. So, for example, the Netherlands and the UK, and they're about to review and potentially revise their strategies. And another country is actually Germany, who until I think 2006 also did the risk-based approach, and since then have implemented universal and have also now just published this year that has also now led to a significant reduction. But this is an approach that requires women to be screened, so they would all have to be swabbed in pregnancy, and then they would have to receive intravenous antibiotics during pregnancy, plus it results in the US about 30% of pregnant women receive antibiotics. So if you now look at the birth cohort in low-income countries and just try to imagine, first of all, the amount of antibiotics that need to be given, plus, of course, what needs to be in place. I think there's a high risk that will not occur in the shorter midterm, that such systems are implementable, plus the antibiotic exposure, given the issues we already have with antimicrobial resistance, etc. So we think that a vaccine would be a much more equitable approach, and then that's one very significant benefit. The other is that what I was just talking about previously is that the 90,000 infant death. So first of all, these include both early onset as well as late onset disease. So the majority of death occur within the first week of life, but GBS disease can occur until 3 months of life. And the current strategy here, so the antibiotic strategy, addresses these infant death, but doesn't have any effect on late onset disease, so which is the ones that occur post first week of life. And they don't have any effect, obviously, on stillbirth because it's too late. They're given at delivery, stillbirth caused, of course, during pregnancy. So the vaccine would hopefully cover a certain percentage, significant percentage of stillbirth caused by GBS, plus also prevent late onset disease. And this is just a different way of looking at it. So that's IAP, the antibiotics, primarily early onset disease, and then GBS vaccine would address all these four entities. The second vaccine, we could also say it's the first vaccine since it's the most advanced in development, is RSV vaccine. So respiratory syncytial virus continues to be one of the most significant respiratory pathogens worldwide in terms of causing I think a lot of morbidity, also related to lung development, asthma, etc. And then also mortality, oftentimes associated with other bacterial respiratory infections. And these are just examples of large ongoing, at first it was just completed, but large ongoing studies. And in all of these studies, RSV was identified as the #1 pathogen causing severe lower respiratory infections. And that's the vaccine that we are supporting, so developed by Novavax, which is a biotech company in the US. And at this time, so that's their only published paper to date, but they're now even more advanced because they're in phase 3 development. And reason why we're now starting to focus on delivery-related aspects, which is ANC, MNCH, is that if this vaccine works, it will likely be licensed within a few years' time, so could be 3-4 years' time. And so we therefore want to start talking about what's country readiness for maternal immunization, what needs to be in place, what needs to happen to make this work, because this would be the first time that a vaccine with a maternal indication gets licensed full stop, and then licensed hopefully near concurrently in high-income and low-income countries. And of course, first vaccine with a maternal indication, which means a vaccine that's entirely developed only for pregnant women, for nothing else. So influenza is, for anybody, and that means that the safety aspects need to be addressed. So we need to know about pregnancy background rates to be able to have a comparator. We have surveillance in place, and then the entire regulatory process plus implementation via antenatal care. And this is where Ajoke, I think, can kick in.
I think we spoke about what's here, the history, 50, 60, 70, 80. We ran through that. I think it's important to remember also that maternal mortality in the lower part of the picture, that MMR has, as Ajoke said, decreased almost 52%, 43% to be exact, in the MDG era. The global maternal mortality is decreasing. We saw many decades of no evolution, but now we are much more optimistic, and part of this is the very rapid increase in facility births. This is from a Lancet series in September 2016. So here's our vulnerability thinking at the Gates Foundation right now, that if you're an adolescent mother, undernourished, anemic, or infected at conception, you run higher risks during pregnancy yourself, but also your fetus will be having various negative effects. If you then survive as a child, sorry, no, I pushed the wrong button. Where there's the pointers here?
Pointer is there. This one.
This one, thank you. So if you succumb, you're lost, but you may also go out of this with a poorer state of health than if you had actually been born with optimal health. So the newborn may survive, newborn, preterm, low birth weight, vulnerable. This is really our thinking instead of, and then the cycle is repeated by the mother who may lose her baby quickly and continue in this cycle of poor, suboptimal health. Where a healthy mother, a Seattle mother at best, would have the ideal trajectory of optimal circumstances during pregnancy, birth, and the baby will not, will be much more liable to survive the kind of temporal trauma rather than being on this trajectory that the vulnerability around birth otherwise might lead to. So we have a number of interventions already around maternal newborn care. We have spoken about antenatal care in general, the tetanus vaccination, and what we're doing around birth. But how can this be complemented? This gap between the interventions in pregnancy and before you can start vaccinating the baby in childhood vaccinations programs. And that's where the maternal immunization comes in, either antenatal care or, as we do today, we actually often give two vaccinations around birth. One is the BCG and the other is the birth dose of Hep B. What about the service delivery context? The antenatal care, how's it going on today? I think we summarized that too. What are the potential effects of maternal immunization on antenatal care quality? Will it overburden the already strained provider, stretched provider, often the same person, by the way, who in the next room is attending deliveries and running back and forth? Can it be strengthened when EPI steps in and helps firm up the program? We have to work on that. Here's an overview of things that we are doing. Many of these, the Gates Foundation. We are working on preeclampsia. We have just completed a very successful study on screen and treat for syphilis in DRC and Zambia. That is, the results of which are now being brought to scale in a whole number of countries by WHO. We're working a lot of quality. Group antenatal care is a very intriguing innovation. Instead of the antenatal care midwife, the midwife providing antenatal care, seeing every woman individually, how can she meet over 2 hours with 10 or 12 women instead and follow them through pregnancy, where there's a much better engagement of women, much higher rate of compliance, even on things like breastfeeding and postpartum contraception. Is that a good platform? We're trying it out in at least 3 sub-Saharan African countries right now. We're working on the monitoring part of antenatal care, what's going on, and these are other things where the platform of antenatal care is being used for these other very important interventions. So antenatal care needs to be strengthened, as we have spoken about. There's a unique opportunity for strengthening the platform. It has, maternal immunization also has benefits for the woman. Let's think of the 2 vaccines that Ajoke has described. Now I hit something here inadvertently. I hit the touchpad. There, we're back again. What did I do, Ajoke?
What are you looking for?
No, I'm just looking back to the presentation.
Yeah, okay.
If you can help me go back to that. So we have 2 immunizations. The RSV that will come here first, that is mainly focused on the newborn, doesn't provide maternal protection. And the other one that addresses the whole conundrum of group B streptococci. I somehow hit the touchpad.
Oh, okay, there it is. I just find that's the cursor.
My mistake. Too clumsy. I got up at 3 this morning to get trained on. So that's why I was clumsy. The conundrum of group B streptococci, which for an obstetrician makes it even more interesting as a maternal immunization. Thank you so much. The RSV, focusing on the newborn. The group B streptococci, this whole business that Ajoke explained, that to screen all pregnant women for group B streptococci, finding that 15 to 30% have the bacteria, and how would you then, in let's say a Zambian setting, would you decide who should have antibiotics by risk criteria, or as they did in my country of origin, they used to test for antibodies, so only the group B streptococci positive, antibody negative ones would get antibiotic. But still, it's a huge apparatus. So if we could vaccinate ourselves out of the whole GBS conundrum, that would be great, both for newborn and maternal purposes. So that's what we're hoping to do, right? Just in addition to what Ajoke said, the other thing that I was thinking about before is that it's very embarrassing how little we know about prematurity, preterm, both when it comes to the causes of why do some women deliver preterm, but actually what kills the baby. You say, oh, it dies prematurely. It weighed 1,800 grams. Yeah, but what did it die from? Did it die from hypothermia? Did it die from asphyxia or respiratory difficulties? Did it die from nutritional difficulties? Or did it die from infection? And only now we are doing those studies. So Ajoke showed a whole series of studies where we are now in much more careful detail in a whole host of countries looking into what is the real cause of death that we have labeled as preterm. And so we think that of the 3 big killers of newborn babies, asphyxia, preterm, and infection, there are gains to be made by maternal immunization, both on the infection side, but perhaps also on the asphyxia side and the preterm side, certainly the preterm and the infection side. So we don't fully know what will be the gains in this epidemiological situation of a certain country, and that's one of the things that the immunization people, as we get the vaccines, they will need to show the value propositions for countries. How do I explain to an African Minister of Health that you need to start doing more in antenatal care to save these babies? Well, how many babies can we save? Well, we don't know fully yet, but there's a big burden out there.